we're going to talk for a minute about a few REI topics. And let me just take you through those. First, congenital adrenal hyperplasia. Be aware, this is the most common cause of ambiguous genitalia. It is an autosomal recessive disorder, and the spectrum of phenotypic disease varies, can be mild to more severe. With a female 46XX fetus, you'll have potentially atypical genitalia with clitoral enlargement, labial fusion, and a urogenital sinus. And this is due to excess androgen exposure in utero. The defect here is in the conversion of 17-hydroxyprogesterone to 11-deoxycortisol. So what happens is the result is very high levels of 17-hydroxyprogesterone and deficient levels of 11-deoxycortisol. And then congenital adrenal hyperplasia is part of routine newborn screening, actually, as well, in the newborn metabolic screens that are done. So again, 95% of congenital adrenal hyperplasia is due to 21-hydroxylase deficiency. I'm not going to cover the biochemical pathway, but if you have a case of this on your case list, it would be interesting for you to take a look at the biochemical pathway so you can see the different steroid hormones that are involved and where the different blocks are in case they asked you. The basic one that most common that I gave you is, again, that conversion of 17-hydroxyprogesterone being blocked. So it results in very high levels. We're going to talk for just a few seconds about puberty. So this gives you the normal adolescent development in chronological order. When we talk about telarchy, this is the development of breasts. It's due to estradiol production from the ovaries. We talk about pubarchy, we're talking about pubic hair and axillary hair. This is the appearance of sexual hair, if you will, this hair in the normal sexual distributions. Adrenarchy is the onset of androgen-dependent body changes, including additional growth of axillary and pubic hair, body odor, and acne from androgens from the adrenals. And then menarche, we're talking about the first bleed due to the effects of estrogen on the uterus. I will just mention that precocious puberty, I would suspect that if I was given a scenario where breast development was noted before 8 years of age. And for delayed puberty, I would suspect that where breast development is not present by 12 to 13 years of age. Again, in the process of normal puberty, we have activation of the gonads by FSH and LH, and we have increased androgen production by the adrenal cortex. So just a very helpful but brief review of puberty. Now, hirsutism, I'm going to spend a little bit more time on this. Very, very common to have hirsutism on our office list. I do want to mention the life cycle of a hair follicle. Hair follicles can be in a growth, resting, or falling out phase. Anagen, growth, catagen, falling out, telogen, resting. So again, about a third of all hair follicles are in each phase at any given time. Up to 50% of hirsutism is familial in origin. And the second most common cause is going to be PCOS. When we think about where do these androgens come from, they are produced in the ovarian theca, the adrenal cortex, and also in some end organs with peripheral conversion. And there are a variety of different androgens that we're talking about. DHEA, DHEAS, androstenedione, testosterone, dihydrotestosterone, all relevant androgens depending on the source that is producing them. So we, again, have to be thinking familial and PCOS as very common causes, and then some less common causes, including CAH, late onset CAH, androgen secreting tumor, thyroid disease, prolactin, Cushing's disease as well. And when we think about the workup, the basic workup, we're going to start looking at some of our androgen components to total testosterone, DHEAS, 17-hydroxyprogesterone. And then let me go to the next slide and we talk about treatment. So when we think about treatment, the multimodal approach is most effective. This can include medications, and it also includes depilation and weight loss if obese. So let me just mention a couple of things about some of the treatments. Weight loss increases sex hormone binding globulin, and thereby it will decrease free testosterone. So that's one of the reasons weight loss can be helpful. OCPs, this is going to include estrogen, obviously. It's going to cause increased sex hormone binding globulin. Some progestins are less androgenic. For instance, drospirenone also has spironolactone-like properties. So some of the progestins are less androgenic, and drospirenone actually has the advantage of some anti-androgen sort of activity like spironolactone. Spironolactone itself is a competitive inhibitor of androgen receptors and also a 5-alpha reductase inhibitor, which decreases conversion of testosterone. And then anti-androgen treatments like flutamide or finasteride. And of course, these are anti-androgens, so they're going to block the effect of androgens. So variety of different treatments. Remember, the best treatment is a multimodal approach, also including depilation, that's physical removal of hair. I mentioned that because hair that's already present will not be impacted by treatment. So especially in the beginning, removal of hair is going to be important. And then over time, it'll be maybe just a part of the overall treatment plan. I want to talk for just a second about abnormal uterine bleeding. We're all familiar with the Palm-Coyne nomenclature. I think this is a great way to remember your differential diagnosis for abnormal uterine bleeding, structural versus non-structural causes, okay? Everybody has at least one AUB case on their GYN list, and a variety of different procedures are used to treat this. And most of us have these on our office list. So again, the differential diagnosis, Palm-Coyne, don't forget that. And then the evaluation. We start with a history and physical. We often think about evaluating the uterine anatomy. We have to remember that the evaluation is somewhat dependent upon the age of the patient and also on other risk factors that may be present. So history and physical and the information we gather initially will help us to refine that diagnosis. And then there are certain laboratory tests that can be very helpful. I do want to remind you that one cause of abnormal uterine bleeding is chlamydia. And so a patient can have that as their presenting symptom. So do think about that. And certain patients are going to present in a way where we should think about the possibility for a bleeding disorder. I think about the adolescent with heavy menstrual bleeding since menarche. We should be thinking about the possibility of bleeding disorder. Of course, the most common bleeding disorder that we might see is von Willebrand's disease. I will mention that a little bit later in this lecture. The first step to deciding whether to screen a patient for a bleeding disorder is to take a history, looking for things like postpartum hemorrhage, surgery-related bleeding, bleeding with dental work, or looking for patients that have multiple symptoms that are maybe less significant, but when put together should increase our risk, like bruising, nosebleeds, gum bleeding, or family history. So again, we start with a clinical screen that might lead us to screen some patients with AUB or a bleeding disorder. And then the last slide I have on this, I just want to talk about the other differentials that come in with age, specifically when should we be doing endometrial biopsy? Any patient 45 or older, we should do an endometrial biopsy as part of our initial evaluation of AUB. If a patient is under 45 but has risk factors like PCOS or anovulation, unopposed estrogen, then we would consider doing a biopsy. If they have persistent AUB, they're under 45, but they have persistent AUB, they're not responding to conservative medical treatment, for instance, then endometrial biopsy. I want to mention ultrasound for just a second. Ultrasound is potentially useful in postmenopausal bleeding for the purposes of assessing for the risk of endometrial cancer. It doesn't have much value in that regard in premenopausal patients. So when I think about premenopausal patients and ultrasound of the uterus, I'm thinking mainly for identifying a structural abnormality like a polyp or submucous myoma, but the thickness itself doesn't really tell me very much. So be careful not to get into the sticky mess of talking about endometrial thickness unless you're advocating that it's describing a polyp or a submucous myoma. All right, I am going to stop right here, and we are right on time for our break, and we will come back and start here in the last office. All right, we are back. I'm going to reiterate two announcements I made earlier in case any of you were not present or didn't hear it. We are going to give recorded access to this course. So if you're on the Zoom course, you just need to email us your testing date, testing month, once you find that out, to info@exampro.com so that we can give you access to the recorded sessions. And I do want to also ask all of you, again, we get most of our candidates coming to us by word of mouth, which is wonderful. And if you are happy and have good things to say, don't forget to promote us on social media, since that's how most people share information nowadays. Nobody ever forgets when they have a complaint, but sometimes people are busy. If you have something nice to say, we really appreciate it. I'm going to go ahead and get into the lecture. We're going to pick up where we left off, and I'm going to start this discussion in our final section of office, talking about contraception. So let me just get slideshow working. Okay, so this slide basically just talks about the fact that when we think about contraception, an IUD has become one of our best choices. It's indicated for just about every patient. There are multiple types of IUDs. Of course, they fall into two categories, the hormonal and non-hormonal IUDs, and I'll mention that in just a second on the next slide. So there are some patients that are really excellent candidates for IUDs, particularly those who are looking for reliable long-term contraception and those who have medical contraindications to traditional combination OCPs as examples. I think about a breast cancer patient. She would be a great candidate for a copper IUD. I think about so many patients that have risk factors for other things like PCOS, great candidate for levonorgestrel IUD for reduction in risk of endometrial cancer. So there are a few contraindications to IUDs. They are listed here on this slide, and you should be familiar with these. Comparing the copper to the levonorgestrel, there are some similarities and some differences. And I told you we'd show you a couple of slides like this. We have grouped all of the progesterone or levonorgestrel IUDs into one column and the copper IUD in the other column. So you'll notice for the levonorgestrel options, there's an 8-year, a 5-year, and a 3-year. If you were not aware, the Mirena is now approved for 8 years. And in fact, off the top of my head, the Liletta probably falls in between, because I don't think I'm gonna have to double check that. I'm not sure if they got the 8-year approval yet. They are going for it, but Mirena definitely for 8. Kylena for 5, Skyla for 3, Liletta, I believe maybe 6 or 7 at this point. I'll have to double check that. Sorry, I didn't think about that because I don't use that particular one. And then copper IUD is good for 10 years, according to the FDA. And there are studies that show that the copper IUD actually works longer than 10 years. So you can find different places people have written about continuing copper IUDs beyond the 10-year point. That is, of course, an off-label continuation. So I really want to just also point out something I said earlier today that I think most people are aware of, but I want you to definitely log in your memory. For emergency contraception, the 52 milligram levonorgestrel IUDs are appropriate, and that was really confirmed in that non-inferiority study done by Planned Parenthood in Utah. I think that was 2 years ago. So the other levonorgestrel IUDs would not be, but the 52 milligram would be the Liletta and the Mirena. So let's go ahead to the next slide. Adolescents. IUD is a great choice for adolescents. We try to encourage adolescents for LARC. I think the safety is clear, doesn't increase the risk for sexually transmitted infections, does not impact future fertility. In the case where we are putting in emergency contraception, the copper IUD obviously is the absolute best choice there, with the longest duration of approved contraception continuation afterwards. and we don't have to give antibiotics prior to doing an IUD insertion. Really, the biggest concerns are the patient's ability to tolerate the procedure. When, for instance, when I'm placing an IUD for an adolescent, I always educate them at a visit first so they can think about it. And I always recommend to use a local anesthetic. I find that a cervical block actually really does help them, but these are options. I think that most patients can tolerate this quite well, and depending on which IUD you use, for instance, the Skyla is a little bit smaller, although it does have a shorter duration of action and it has some different bleeding expectations. And this is the kind of discussion. The reason I'm telling you this story isn't because you care what I do, but this is the kind of discussion that I would anticipate you will get into when the examiner asks you, tell me, how do you counsel patients about the IUD options in helping them to understand the benefits, risks, and alternatives to choose between the different devices available? Okay, that's kind of long-winded, but they might shorten it up and just say, how do you counsel a patient about choosing between the different IUDs? Same question. Okay, so do be prepared for those kind of questions. Do be prepared to discuss IUDs as a very favorable LARC method. Also, the implant, it is also a favorable LARC method. I don't have a slide on it, but it falls into the same group of contraceptive choices. It has its own pros and cons, relatively shorter duration, a 3-year approval, but still a very effective method, the most effective for pregnancy prevention. I'm going to talk for a few minutes about OCPs. OCPs are unique in that they have a lot of non-contraceptive benefits. So, and some of the other contraceptive methods do as well, but OCPs have a long history of being used not only for pregnancy prevention, but in a patient who also desires regulation of cycles, decreased menstrual bleeding, reduction in menstrual-associated or non-menstrual associated pelvic pain in the cases of chronic pelvic pain with endometriosis, which really is menstrual-associated in my mind. But the bottom line, also benefits of reducing iron deficiency anemia, decreased risk of PID, the decreased risk for endometrial cancer and for ovarian cancer. So there's a lot of, not to mention the effects on skin and on hair growth that are favorable, a lot of non-contraceptive benefits. So OCPs still very much a part of our practice. This is a topic that I'm about to cover that is really important if you get into a discussion of OCPs. There are certain medical issues associated with OCPs. The first is to remember that we can use OCPs into the mid-50s in healthy patients. So a patient that is on OCPs for cycle regulation and contraception doesn't have to struggle, if they're healthy, doesn't have to struggle with what to do as they approach menopause. They can continue them really until the onset of menopause. Unfortunately, as we age, we are more likely to have other medical problems that might impact OCP use. One of them that you should, and I expect you are aware of, and the examiners will expect you are aware of, is hypertension. If a patient has hypertension, even if it's well controlled on medication, OCPs are considered a poor choice. They are contraindicated. Another that I want to highlight is the use of OCPs in patients with migraines. I think you're probably familiar with this as well, but migraines with aura, when we use estrogen-containing contraception, we increase the risk of stroke. Okay, so that's a reason not to do that. I want to mention when we have a family history of breast cancer. This is a situation that's slightly different. The OCP does not increase the risk of a patient, even BRCA1 or BRCA2, to develop breast cancer. And it does decrease the risk of ovarian cancer. So this is a patient that has a medical problem that actually we would favor OCPs for the risk reduction component regarding ovarian cancer. I have a couple of other things I want to mention on the following slide, which is on the same topic. So really, the two things on this slide that I want to highlight. First is what to do with a patient on OCPs who's going to undergo surgery. because we all know that OCPs are associated with increased risk for VTE, and surgery is associated with increased risk for VTE. If the patient is going to ambulate on the day of surgery, then you don't need to stop the OCP. Okay, so this is how the best litmus test I can give. If they are expected to ambulate post-op, you don't even have to think about it. You don't have to stop the OCP. And the advantage to this is that when you do stop the OCP, you now have the possibility the patient gets pregnant in the pre-op period, and that creates a whole bunch of new issues. If the patient is expected to have prolonged immobilization following their procedure, this is a relatively small group of procedures nowadays because we're so much more outpatient, minimally invasive, and aggressive about resumption of normal activity. But if a patient is expected to have prolonged immobilization, if they're not going to ambulate in the first few days following surgery, then I would stop the OCP 1 month prior. Okay. The last thing on this slide that I want to highlight is antiphospholipid antibodies. Now, lupus is not a reason that a patient can't take an OCP. So if you have lupus, you can take an OCP. But if you have antiphospholipid antibodies, you should not take estrogen-containing contraception. So when we talk about antiphospholipid antibodies in the OB section of the exam, I would want to hear you mention at the postpartum hospital care that you would talk about contraception, specifically because you would want to make sure the patient did not use estrogen-containing contraception, and you would talk about other options. If we're talking about lupus and OCPs in a non-pregnant patient, I would mention antiphospholipid antibodies just as an aside. If they had antiphospholipid antibodies, that would be a reason not to take OCPs. Some of the contraindications to OCPs, and they're fairly common sense. Breast cancer, if they have cancer. Okay, now family history of breast cancer, no, as I said previously, but if the patient who's going to take the OCP has breast cancer, we would say no. Any estrogen sensitive tumor, pregnancy, obviously too late, not going to take an OCP. And then as I go down this list, there are a variety of different potential contraindications to OCPs. Now, notice known inherited thrombophilia. One thing I always think when I see this is sometimes in our brain, we change up the word when we look at it. When I see known inherited thrombophilia, sometimes I see known inherited coagulopathy. And of course, that would have nothing to do with an OCP. An OCP would actually potentially improve von Willebrand's situation. But for a thrombophilia, it like factor V, that would be a problem. So I just point that out because one thing that sometimes happens in the oral exam is that you'll be talking about a topic and you'll do one of these little miscues in your mind and you'll realize it. And then you'll get into the next topic and all of a sudden you'll have like this epiphany. Oh my God, I can't believe I did that. People ask me all the time, how do I handle that? If you've moved on and you're well past it, don't even worry about it. They understand. They're not going to give you credit, but they're not going to fail you for it. If you just finished that discussion, then just correct yourself. I realized I was talking about this when you asked me about that. And then if they want to redirect, they will, but usually they want to move on. So don't worry about it. And that's one of the things in the oral exam that I think is so critical. Be comfortable with yourself. Realize that nobody knows everything. All of us on our best day still make little mistakes. Practice, develop strategy, stress yourself out before you go to Dallas. That's what we're all about, trying to help you do that, so that when you get to Dallas, you will do the very best that you can possibly do. And just realize that it's just a process, and you are a good doctor, well prepared. And if you continue to work on this format and not to obsess about the little things, you'll be fine. And that's what we find again and again when we work with people, is that the slightest little pieces of information can make huge differences. And that's why we're still here. And that's why we plan to be here long term. So let me move on because I digress. Contraindications to OCPs listed here. Okay. I'm going to take a few minutes to talk about hormone replacement therapy, we're talking about here in menopausal patients. Okay. Now, I want to mention that sometimes topics gain traction in the exam when they are potentially commonly managed in ways that kind of go against the science. So they become a little bit more important to the examiners when there's a kind of a lot of management going on in, in the world, that doesn't always kind of go with the science. And so let me just mention with hormone replacement therapy, the things I'm getting at here is that there are a lot of patients who are good candidates who are denied access. There also are a lot of patients who are given prescriptions for products that are less than ideal. And especially when we talk about anti-aging or bioidentical hormone therapy, the data is not there. In fact, there are concerns. ACOG has really latched onto this and emphasized this. And I've noticed that in the past few years, they give talks at the annual meeting on this topic. They have publications that are out there on this topic, and they're all very consistent. And so what we're going to do is just take you through a little bit of background information. And I'm going to start that with the Women's Health Initiative study. Why am I starting with this study from 2 decades ago plus? I'm starting with this because the Women's Health Initiative study was kind of a turning point. Well, it was a study among multiple studies at that time, but it was a first study that really, I think, altered clinical practice in some significant ways. And it made us think about hormone replacement as something that wasn't universally applicable to every single woman at the time of menopause. Because prior to this, hormones were almost like vitamins, and maybe they were a little bit overutilized. And then after the Women's Health Initiative, there perhaps was a little bit of a backlash and a little bit underutilization. And so I'm going to start with this study just so you have a little bit of background in case you get into a discussion of hormone replacement therapy. This slide summarizes what I'm going to go over with you. And so I'm not going to read it because I'm going to go ahead and go over each of these with you. So first of all, what did it actually assess? It was a comparison study to the HERS study. And the primary outcome that this study looked at was cardiovascular disease, specifically myocardial infarction and acute coronary death. And the primary adverse outcome was invasive breast cancer. And there were about 161,000 women. They got hormone replacement therapy, low-fat diet, calcium and vitamin D supplementation. This was a prospective trial. They didn't all get all of these things, but these were the interventions that were used. The study arms included the placebo. Obviously, they're not getting any active medication. The conjugated estrogen and MPA when patients had a uterus present. And I do want to point out that MPA was the only progesterone used in this study. And I think that we have better progesterones today. So some of the outcomes of this study, again, over time, may not be as significant as we change the combination of medications that we're using. And then the third arm was conjugated estrogens if they did not have a uterus. In the study arms, 27 in the follow-up, 27,000 healthy women aged 50 to 79, average age 63, average follow-up was 5 years. So in summary, what the study really found was that there was no increased mortality in the hormone replacement or estrogen replacement groups when compared to placebo. So overall, looking at mortality, it really wasn't increased. So that hormone replacement from that standpoint would be safe. And they looked at a subset of different things. And in fact, I'm gonna go ahead, this list of things, I'm gonna go ahead to the next slide. They looked at MI and cardiovascular disease, stroke, VTE, breast cancer, colon cancer, fractures, and diabetes. Now, when you look at this slide, the two columns, E/P, of course, estrogen, progesterone, EE is estrogen alone, and the numbers are either greater, if it's a plus sign, greater number of events compared to placebo, or less number of events compared to placebo if it's a minus sign. So if we look at this, we can clearly see on the line for VTE that there were increased VTE events compared to placebo in both arms. And that makes sense. We would expect that. If we look at the issue of breast cancer, which a lot of people do worry about, not so clear. Potentially an increase in the estrogen progesterone arm, but potentially decrease in the estrogen arm. Doesn't really make sense. And another thing that didn't really make sense out of that was that the patients that were diagnosed with breast cancer who'd been on hormones often responded better to treatment for breast cancer than the patients who weren't on hormones. So again, the information that came from here, some of it was expected and clear, and some of it was not as useful. It didn't really lead to any changes. One of the things that was most remarkable was the fracture data. Look at that, -47, -56. I mean, by an order of magnitude, the fracture data outweighs all of the other outcomes. There was no doubt that hormone replacement therapy lowers the risk of fracture. And this was the first study to show that, okay? So why don't we use it as a treatment for osteoporosis? We don't use it as a treatment for osteoporosis as a primary treatment, because when you weigh all of the risks and benefits, it just doesn't favor that when we have other options. So for a patient who has menopausal symptoms, who's thinking about hormone replacement, a secondary benefit or secondary gain is prevention of fracture. But for a patient who doesn't have any reason to take hormones for menopausal symptoms, it's not appropriate to prescribe hormone replacement for this purpose, for fracture reduction. All right, so let me go through this. The conclusions that we took away from the Women's Health Initiative. First, we should individualize hormone replacement management based on a patient's symptoms, potential risks, and her medical history. Second, when we do put a patient on hormone replacement therapy, we should use the lowest effective dose for the shortest duration required to accomplish our treatment goals. And our treatment goals are really the reduction of life-altering vasomotor symptoms. And so I think this is what we do today. We use the lowest effective dose for the shortest duration to accomplish the treatment goals. Now, hormone replacement therapy or estrogen replacement therapy is indicated for management of vasomotor symptoms, localized hormone replacement for vaginal dryness, and as a secondary indication, it also helps with fracture prevention. It is not indicated for reduction of heart disease, although there are ongoing studies about the timing of hormone replacement in conjunction with the onset of menopause and the risk-benefit equation related to heart disease, depending upon the timing of when hormone replacement is given. So there are still some studies looking at this issue, but in general, it is not felt to be a preventative for cardiovascular disease. It also is not shown to improve cognitive function or prevent Alzheimer's disease. Now, there were a couple of other studies that are worth mentioning since we're talking about studies here. First, looking at HERS and HERS2, these studies showed some cardioprotective effect when estrogen and hormone replacement therapy were given close to menopause. That's that timing that I was talking about a minute ago. Also showed some lower coronary artery calcium scores. So again, coronary artery calcium scores are somewhat controversial, but have become more widely accepted as potentially indicators for risk for cardiovascular disease. So again, these studies do push forward that question, and there is ongoing research here. The estrogen and thromboembolism study looked at VTE risk, and it looked at route of administration of estrogen alone. And you can see when you look at this, the relative risk was higher with oral estrogen. That means it's higher than placebo. And the relative risk was actually slightly reduced, because 1.0 would be the same, was slightly reduced with transdermal. And so this is an important point, because the best approach, the best practice for hormone replacement, if you're talking about it in the exam, is to always recommend transdermal hormone replacement therapy where possible, because the route of administration influences the metabolism. Of course, there's the first pass effect related to that, and it lowers the risk for VTE. So again, the point is that we can individualize therapy for patients who have indications, and we can make it as safe as possible and continue it only as long as it's necessary. There are some contraindications to hormone replacement, including the common things we would expect: estrogen-sensitive cancers, undiagnosed symptoms like vaginal bleeding, liver disease, history of VTE or thrombophilia. Hold on, I'm going to sneeze. Sorry. I always chuckle when I think about pregnancy on this list, because I don't really think about pregnancy and hormone replacement therapy interacting with each other, and yet delivered some patients that were in the age range where they might have taken hormone replacement therapy. So it's not a joke. It's real. If there are pregnancy would be a reason not to take it. Of course, patients with active heart disease or history of a stroke, they're not going to be good candidates either. Also, I want to mention a contrast to OCPs. If I asked you about migraine with aura, hypertension, or smoking, you would hopefully tell me that those are all contraindications to OCPs. They're not absolute contraindications to hormone replacement therapy. And part of the reason for that is we're talking about much lower doses of hormone in hormone replacement therapy than we are in contraceptives. So just a little contrast between the two, somewhat of a tricky question if you hadn't thought about it. And I'd hope that this will help you in case it comes up. So one little thing about how to approach hormone replacement therapy. So actually not one little thing, a couple of points. So continuous hormone replacement therapy can be prescribed if a patient is 2 to 3 years from her last menstrual cycle pretty confidently without causing bleeding. In patients who are more recently menopausal, you might want to consider a cyclic approach for the reason of minimizing breakthrough bleeding, okay? And again, usually with something like a estrogen-containing patch, and it can also contain progesterone or oral micronized progesterone if the patient needs that. When we talk about a cyclic approach, then I would probably use the oral progesterone because that would be the easiest way. That doesn't make sense because you can also do a patch in a cyclic way. Ignore that. And the bottom line is that combination versus cyclic can be appropriate when we're talking about the timing for menopause and trying to minimize breakthrough bleeding. Other things on this slide that are specifically outlined that I want to make sure I don't miss. Once we stop hormone replacement therapy, so once a patient reaches the point where she feels like she's willing to take a holiday, about 50% of patients will have recurrent symptoms and we'll end up retreating them. And it doesn't really matter whether we taper the hormone replacement, I was going to say HRT, but the hormone replacement, or whether we just stop it cold turkey. I already mentioned that the type of hormone and the delivery system matter. Medroxyprogesterone acetate, probably the worst. Micronized progesterone, better. Oral estrogen, the worst. Transdermal estrogen, better. Again, just putting those trends in writing for you. When we talk about vaginal estrogen creams and tablets, very minimal systemic absorption, really no increased VTE risk if used according to the current prescribing guidelines. So one of the issues that comes up is at what age should you stop hormone replacement therapy? And there are some organizations that have publicly advocated for stopping hormone replacement therapy at age 65. ACOG and NAMS recommend against routinely stopping hormone replacement therapy at age 65. And the reason for this is that not all women are going to respond in the same way. There are some women who feel like the benefit, the symptom relief continues much longer than other women whose symptoms will ameliorate at a much more rapid pace. We can safely initiate women hormone replacement therapy in women who are less than 10 years from menopause and less than 60, and we can continue it if they remain healthy without contraindications, so long as they need it for control of their symptoms. One thing to consider is calculating cardiovascular disease risk and breast cancer risk before starting hormone replacement therapy. This can be part of shared decision-making with a patient. There is a NAMS app that actually calculates both cardiovascular risk and breast cancer risk. So that can be one way you can do this. And when somebody has elevated risk, then we usually are not going to recommend hormone therapy. When patients have lower risk, then it would be reasonable. And so the other thing that I want to mention here is, and by the way, there are thresholds and numbers for elevated versus reasonable risk. So I think of high cardiovascular risk, greater than 10% in the next 10 years. Moderate cardiovascular risk would be 5 to 10% in the next 10 years. with breast cancer risk. Moderate risk is 1.67 to 5% over 5 years. High risk greater than 5% over 5 years. So when we have a patient with elevated risk, we're going to think about non-hormonal options for management of their menopausal symptoms. And the other thing I wanted to mention is this last line: compounded bioidentical hormone therapy not recommended. This has been clear and consistent for quite a few years. There are a number of concerns about compounded bioidentical hormone therapy. Most of the commercially produced products are bioidentical. So this is kind of a confusing term. And they're much more reliable regarding the dosing, the amount of active ingredient contained. And they have been more carefully studied regarding the risks and benefits, potentially because any compounded product will differ from any other compounded product. So you can't necessarily throw them together and assess level of risk. So from that standpoint, compounded bioidentical hormone therapy not recommended. It is definitely a topic I would prefer not to get into in the oral exam. What I mean is, if they ask me about it, I would say I don't recommend it. And if you chose to say, oh, I think it's great, I do it all the time, then you're opening up a difficult discussion that can be hard to get out of, because there are a lot of concerns, and it's been fairly consistent from ACOG that this is not the best approach. So I don't want to set anybody off who may have inadvertently noted this on their case list. It's not a problem. If you have a case where this is mentioned, just reach out to us, and we can talk about it offline, because often there are things that you can introduce into the discussion that can help you to present it in the most favorable way. I'm going to continue on here. Non-medical options, non-medical meaning they don't involve any kind of prescription. There's a nice list here, and these are mostly behavioral modifications and some holistic treatments that may improve. I do want to point out exercise improves quality of life, but the studies on it don't clearly demonstrate decreased vasomotor symptoms. So maybe better ability to compensate or deal with vasomotor symptoms, but not necessarily a reduction in the frequency of those symptoms. When we think about non-hormonal therapies, by the way, progesterone obviously is hormonal. It's not a first-line treatment, but it's listed on here because it's a non-estrogen containing product. So SSRIs, SSNRIs, paroxetine 7.5 milligrams per day is the FDA-approved SSRI for reduction of vasomotor symptoms. Gabapentin off-label, clonidine off-label, non-hormonal alternatives. Of course, progesterone is hormonal, not routinely recommended as hormone replacement therapy, but does show up in publications. So with that said, I am going to move past the hormone replacement discussion, but I cannot understate the importance of feeling comfortable talking about hormone replacement therapy in the exam. So if you're not, I want you to practice it. Okay, DES. We're kind of getting to the point where DES is not a clinical issue that we see. We're getting to that point because it was taken off the market so long ago. In 1971 was when it was taken off the market. I do want to just mention that DES, it's the fetus inside the mother, who, of course, is the one who has the consequences. If the mother took DES while pregnant, exposed her female fetus to this medication, then there are some gynecologic concerns. And we've listed here some of the consequences. There is a recommendation for a DES daughter, meaning the fetus that was in the womb that was exposed, for surveillance. Annual PAP, colposcopy of the cervix and vagina, also done annually, and this is done indefinitely. We would not stop this at any specific age. We would do this for life. When we do these exams, we want to visualize the entire vagina, rotate the speculum to make sure that we see the vaginal walls all the way around. If the patient had a hysterectomy, we would still do annual vaginal cytology and visualization. So be familiar with this in case it comes up. It's becoming a little bit less high yield over time. Von Willebrand's disease. So one thing about von Willebrand's, we'll talk about genetics in a few minutes. It's a unique condition because the different forms are inherited in different genetic fashions. So type 1 is autosomal dominant. It is the most common, but it is the least severe, thank God. And it's associated with decreased amount of von Willebrand's factor production. Type 2 is autosomal dominant or autosomal recessive. It is associated with dysfunctional von Willebrand's factor. There's a normal amount, but it doesn't work properly. Type 3 is autosomal recessive. It is absent or severely deficient von Willebrand's factor. And so I just in a couple sentences kind of differentiated the 3 different types for you. If you have a case of von Willebrand's on your case list, I would definitely be comfortable to talk about that. When we look at women with heavy menstrual bleeding, and in particular, when we look at adolescents with heavy menstrual bleeding since the onset of menarche, this can be associated with higher rates of von Willebrand's disease, and the range is anywhere from 5 to 25%. Other risk factors that clue us in: history of postpartum hemorrhage, bleeding during surgery or with dental procedures, family history of bleeding problems, frequent nosebleeds or bruising, gum bleeding with tooth brushing. So when we are suspicious, first thing we would order a set of coags. And then for a von Willebrand's evaluation, ACOG does recommend that we involve our hematology colleagues because interpretation of the test results can be somewhat difficult from the von Willebrand's panel. Okay, so I would just, you can talk about the tests that would be ordered, and ristocetin cofactor activity is the best. But again, we're going to refer the patient to hematology for completion of that evaluation. We are going to be involved, if she is diagnosed with von Willebrand's, in managing her gynecologic bleeding issues. OCPs, levonorgestrel IUD, are good for this. Desmopressin, which is also known as DDAVP, may be prescribed. This actually increases the amount of von Willebrand's factor that is released from the endothelial cells. So that's how that helps. And then, of course, there are other treatments: antifibrinolytics, plasma-derived concentrates. We want to avoid things that would affect the control of bleeding, like NSAIDs and aspirin. And I think that's everything I have on this. So I'm going to go ahead and move on. I'm going to talk about a couple of primary care topics that come up often enough that we want you to at least have thought about them. The first one is skin lesions. So as a primary care doctor for women, you may be asked about skin lesions, in particular malignant melanoma, which is 2 to 10% of all vulvar cancers. And the vulva, if you think about skin surface area, represents about 1% of the body surface area. So malignant melanomas, for whatever reason, are overrepresented in that area. And so that's one thing to think about when we are evaluating a patient's skin lesion. The characteristics that we use to differentiate something that's likely benign from something that's potentially malignant, the ABCDs. And this is a medical school thing. It's not hard, but just remember, it'd be nice to mention that. Well, if a patient has a vulvar lesion, if it's a pigmented lesion, I'm looking concerned about melanoma, and I think about my ABCDs. Also, don't forget that BRCA2 is associated with an increased risk of melanoma. So number of reasons why we think melanoma is worth presenting to you in this course. I'm going to go on. I'm going to talk about headache for just a second. So I think your most likely discussion will have to do with migraines. And I will point out that tension headaches are actually more common in toto. But when we think about headaches that present to a doctor's office, migraine headaches are the most common because many tension headaches are managed by patients over the counter without seeking medical care. So with migraines, of course, migraine with aura versus migraine without aura is an important distinction because of the contraindication to estrogen-containing contraception with migraines with aura. And for that reason, I think there is a slightly increased chance that you will be asked about the criteria. So we have given you the criteria for migraine without aura and migraine with aura on this slide. Remember that when we talk about a headache, the prodromal phase, this is the 24 to 48 hours before the onset of head pain in people with migraines. And they often have some specific symptoms. There may be food cravings or neck stiffness, increased yawning is something that's been reported. Irritability and changes with a depressed mood can be associated. And then we can see in patients post-migraine where they can actually have a post-drome after their head pain is gone. And this can also last 24 to 48 hours and be characterized in many cases by significant extreme exhaustion, okay? When we think about an aura, so we talk about a migraine with aura. So aura can be visual, sensory, speech and or language associated, motor, brainstem, or retinal. Visual are the most common auras, often presenting as blurred vision, zigzag lines, or scotomata. Sensory auras described often as pins and needles. And when we talk about motor, we think about weakness. So, auras are reversible, and they usually last for a period of minutes, not hours. And the headache follows the aura with symptom-free interval in between there. So I do want to mention one other thing. I think I have another slide on it. I want to talk about migraines relation to menstrual cycles. So the pure menstrual migraine is a migraine that occurs during the 5-day window, starting 2 days before the onset of menses, and then for 5 days from that point. Patients with pure menstrual migraines only get their migraines during this period of time. And part of the thought behind this is that estrogen withdrawal may trigger migraine in women who are predisposed. The pure menstrual migraine is less common than menstrual related migraines. The menstrual related migraines is more common, where a patient can have menstrual migraines, like I just described, but they also have migraines that occur outside of that time frame. So that's the more common scenario. When we think about treatment of menstrual related or pure menstrual migraines, there are a variety of different treatments that can be used. We can use prophylactic treatments with triptans. We can use non-steroidal anti-inflammatories in some cases, sometimes combined with triptans. And we can use extended cycle OCPs to try to eliminate potentially the hormonal changes that might precipitate headaches. And in general, patients who get menstrual related migraines, the symptoms are the same as non-menstrual migraines. It's just the association, the timing that is the difference here. Okay, I'm going to move on. I'm going to talk about infectious diarrhea for just a second. Another primary care topic that is just too relevant and too common not to mention to you, comes up in these kind of exams. So I'm going to just talk about a couple of things. First of all, traveler's diarrhea. These are usually mild to moderate symptoms, watery diarrhea. They may have low-grade fever, sometimes vomiting, sometimes not. The treatment of traveler's diarrhea initially is supportive therapy. The antibiotic of choice used to be Cipro, not recommended anymore. So the antibiotic of choice for traveler's diarrhea is azithromycin. But remember, the initial treatment is supportive care, staying hydrated, anti-motility agent to try to reduce symptoms, and then really only medical antibiotic treatment for prolonged persistent cases. Now, I want to mention just briefly about Giardia. So Giardia is a slightly different scenario. It's often associated with untreated water sources, people that have been camping or traveled into international destinations. There's an incubation period, 7 to 14 days. So it's a lot longer sort of delay between the exposure and the onset of symptoms compared to traveler's diarrhea, which is often food-borne associated diarrhea. So with Giardia, the individual will have watery diarrhea as well. There tends to be more of a bloating and gas type of symptoms. It is diagnosed with fecal exam. The diagnosis can be made with direct immunofluorescence assays against the cyst or trophozoite antigen in the stool. And when we diagnose Giardia, the preferred drug of choice is now tinidazole, 2 grams by mouth times 1 for individuals who are over the age of 3. So the good news there is it's a single dose therapy. The other thing here, when we have a situation where we have a patient with given like a structured case and there's bloody diarrhea presented as part of that, we have to now be thinking about a slightly different group of causative organisms. The one that I want to draw attention to that hopefully you would immediately think about would be the patient's antibiotic history, and specifically whether or not C. difficile might be a possibility for the cause of their diarrhea. So bloody diarrhea, think about C. difficile, patients recently on antibiotic therapy. And I think it's worth looking at C. difficile, especially if you have any diarrhea on your case list. I would look at C. difficile just to be a little bit more familiar with the management there, even though it's not something I think you're routinely dealing with. Okay, I'm going to spend a few minutes on PCOS. So the other name, as you are all familiar, this slide tells us hyperandrogenic chronic anovulation syndrome. I don't think very many people call it that nowadays. PCOS is so widely known. And when we think about secondary amenorrhea, PCOS represents a third of those cases, very important. The signs or symptoms, some of them can be present, or you can have almost all of them present. So changes in menstrual pattern, specifically less frequent or absent, hirsutism, obesity, infertility, pelvic pain, polycystic ovaries on ultrasound. Also, there are metabolic signs and symptoms that might not be known because in these patients, especially if they're younger, there might not be any reason to look at, for instance, their lipids, okay? But PCOS, I think of it as having three components: the gynecologic component, which has to do with menses and cancer risk, the obstetric component, which has to do with infertility predominantly, and the medical component, which has to do with the metabolic changes related to insulin resistance and the metabolic syndrome, which can be associated with PCOS, and I'll touch on in just a second. So insulin resistance and a diagnosis of the metabolic syndrome often associated. And so we have to think about those two things with any patient with PCOS. And let me just go ahead for a second. The diagnosis, there's not a universally accepted definition, but the Rotterdam criteria is the preferred and most commonly used approach. Patient must have two of the following criteria, the three criteria listed: oligo or anovulation, hyperandrogenism, either by clinical or biochemical verification, and polycystic ovaries. Now, regarding the ovaries, so we're talking about ultrasound, and it only requires findings in one ovary to be consistent with PCOS. This can be increased number of small follicles in one or both ovaries. Sometimes, actually, I always remember this, you can see patients with PCOS have a increased AMH because of the small preantral follicles. Anyway, PCOS, increased follicles or increased ovarian volume, only one ovary has to be involved. Okay. Treatment. I'm sorry. Further evaluation. Labs, looking at androgens, ruling out other causes of the presenting symptoms, because remember, PCOS, the symptoms could overlap: congenital adrenal hyperplasia, hyperprolactinemia, androgen secreting neoplasms, thyroid disease. So that's why we would consider some of these other lab tests. Now, I'm not reading the slide to you so much as setting up the next comment. In the exam, any lab test that you profess to recommend or desire, it could be you wrote a lab test on your case list, or you might have just written laboratory evaluation and they say, tell me what laboratory evaluation would you do? Any test that you do, they will ask you, well, of course, what is the, they may ask you, what is the reference, the normal result, abnormal result you're looking for, but they're going to also, more importantly, ask you why. How does this test change your management? Okay, so for any test you do, 17-hydroxyprogesterone, I'm looking for CAH. Okay, so again, any test you do, you should be comfortable to talk about how it impacts your management. Okay, of course, because metabolic abnormalities can be part of PCOS, and if they're present, we like to treat them, we do look for insulin resistance as well. Treatment, the hardest part of PCOS is that lifestyle, long-term adoption of a healthy lifestyle is the most important. It is very difficult because these patients are somewhat predisposed to slower weight loss, less response to interventions, behavioral interventions than a non-PCOS patient, but consistent implementation of healthy lifestyle behaviors related to weight loss and exercise, really, really critical for the long-term benefit. In fact, I think just last month I was reading where a study came out, they verified that life expectancy is slightly reduced in patients with PCOS. It is so difficult to overcome some of these metabolic changes that impact long-term health. So menstrual disorders, we generally treat those with hormonal regulation, and we also deal with prevention of endometrial cancer in the same way. Impaired glucose metabolism in PCOS, when we institute medical therapy on top of lifestyle changes, we usually use metformin for this. And for ovulation induction, letrozole, which is more effective in these patients than clomiphene, but is an off-label use. And so I've mentioned several times during today's lectures, off-label. When you use a medication for an off-label use, I'd be prepared to volunteer that information in the exam so it's clear. It's something you should volunteer to patients. It's not that it's not appropriate. It's just that it has not been FDA approved for the indication that we're using it for. And of course, clomiphene, classic medication for ovulation induction, is also an option. The metabolic syndrome, it is covered in the same practice bulletin that covers PCOS from ACOG. It is high yield. You have these 5 components: central obesity, that's judged by waist circumference, fasting triglycerides, HDL, blood pressure, and glucose. And the numbers are probably worth memorizing if you can, but if you can't memorize the numbers, at least know the 5 components. If you have 3 or more present, you meet the criteria of the metabolic syndrome. What we're really saying is that you now have an increased risk of heart disease because you have multiple factors that are associated with the risk of heart disease. Remember, heart disease, I think I've said this several times today, leading cause of death for women in the United States. Anything we can do to reduce that risk, very, very important. I'm going to just for a few seconds talk about infertility evaluation. ACOG has a committee opinion on, I think the title is infertility evaluation for the generalist, something like that. So you should be comfortable with what is your definition of infertility. And this would be failure to achieve pregnancy within 12 months of unprotected intercourse or attempted conception with donor insemination in women under 35, or 6 months or more in women over 35. So we should offer infertility evaluation to any patient who by definition has infertility or who's at high risk of infertility. Women older than 35 should receive an expedited evaluation and undergo treatment after 6 months rather than waiting 12 months. If they're over 40, immediate referral for further evaluation and treatment to REI would be completely appropriate. If a woman has a condition known to cause infertility, immediate evaluation would also be appropriate. Remember, very important in infertility, male factor is present in 40 to 50% of cases. So although we do see couples where the male is unwilling to be evaluated, that is a big disservice to the patient and to her treating physicians because it is so common. So we want to encourage male evaluation in these evaluations when they are done. When we think about female factor, there are history, physical, lab tests that we can look at, looking at infertility. AMH is one that is commonly mentioned, produced by granulosa cells, can be measured at any time during the cycle. Antral follicle counts are also a way of looking at the follicles. Their antral follicles are 2 to 10 millimeters in diameter. So when we look at AMH, it's similar to antral follicles in its ability to predict the response to ovarian stimulation and pregnancy with infertility treatment. Antral follicle counts, as I mentioned earlier, can be increased in women with PCOS or decreased in patients with hypothalamic amenorrhea or using certain hormonal treatments. So, again, these are just 2 different ways that we look at ovarian reserve, which is really related to pregnancy with infertility treatment. Ovarian reserve tests are not necessarily predictive of the ability to conceive and have a live birth spontaneously. So just keep that in mind. And then as we go down the list, there are other factors that can be used in infertility evaluation. Progesterone is often used to document ovulation, and a progesterone value greater than 3 nanograms per milliliter is considered evidence of ovulation. Assessing for tubal factor, very important, because none of our medical treatments are going to, for ovulation induction, are going to help if the patient has tubal blockage. So tubal factor assessment. Uterine factor sometimes can play a role as well. And so looking for any uterine anatomic abnormalities that might be involved. And then male factor, as I mentioned, semen analysis is critical in that regard. Even in a male who gives a history of previously fathering children, things can change with age or with life experience, like surgery or illness. Also, some males may believe they fathered children, but if paternity testing wasn't done, I'm not trying to be funny, you never know for sure. So again, male factor should involve a semen analysis beyond just the basic history. I'm going to lastly just mention that there are certain tests that have been advocated by ACOG that should not be part of a routine infertility evaluation. That does not mean that these tests should never be done. It just means that they're not part of the routine infertility evaluation. I'm going to just draw attention to prolactin as an example. Prolactin is something that many of us order somewhat routinely in our infertility evaluations. But the argument would be, and it's a sound argument, that if the patient has normal, regular menstrual cycles, then prolactin is not likely to be the cause of her infertility. So in certain patients with menstrual irregularity, prolactin would be a very reasonable test. And in other patients, myself and your examiner would think, that's not so good. So again, I caution you, whenever you order a test, it should have some direct utility to your management of that patient. And please keep that in mind. All right, we are going to move on into our next section. We are going to talk about genetics. I'm just checking where we're at on time here. And we are doing good. All right, so genetics is a very, very important part of what we do. It has become so much more of what we do in OBGYN than it was 20 years ago. I'm going to specifically focus on really prenatal genetics for the next few minutes. We talked a little bit earlier in the talk about BRCA, and there are just a bunch of different genetic applications in medicine today, but right now we're going to talk a little bit about prenatal. So I want to mention that it always surprises me when I ask a candidate, tell me an autosomal recessive condition, and they struggle to come up with one or two. Tell me an autosomal dominant condition, and they struggle to come up with one. These are medical student questions, and you should definitely be familiar with some of the more common autosomal recessive and autosomal dominant conditions, especially as an OBGYN. So we've listed here some of them for you. In the cystic fibrosis carrier frequency that's listed, that's for Caucasians. Tay-Sachs carrier frequency that's listed, that's for Ashkenazi Jewish. The sickle cell carrier frequency that's listed there, that's for African Americans. Remember that von Willebrand's disease can be autosomal dominant in the most common form. That's also the least severe. And it can be autosomal recessive, which can occur in type 2 or type 3. Type 2 can occur either autosomal dominant or recessive. So if you were struggling and they said, tell me an autosomal recessive or autosomal dominant condition, say von Willebrand's, just don't say 1, 2, or 3. Okay. And you'll have the right answer. All right, I'm going to continue on, but I think you see my point. Basic stuff can sometimes make us look worse than we actually are. Let's talk for just a few seconds about X-linked. X-linked, of course, has a very specific pattern of inheritance, and so often can be identified by looking at a pedigree. Fortunately, this is not the written exam, so I do not anticipate that they're going to give you a pedigree. We think about common X-linked things: hemophilia, Duchenne's muscular dystrophy, and red-green color blindness. I think one that is higher yield that may come up in the oral exam would be a discussion of Fragile X. We'll talk about that in a minute. And then the other mode of inheritance is multifactorial. Now, let me just mention multifactorial inheritance. It means that both genetic and environmental factors contribute to the occurrence. Okay, so for instance, there are five known genes that contribute to non-syndromal cleft lip and palate. Cleft lip and palate occurs in, as the slide says, about 1 in 700 live births. 70% of cleft lip and palate are due to multifactorial causes, a combination of genetic and environmental causes, whereas 30% occur with recognized syndromes. So those would be specific genetic syndromes in which cleft lip and palate are a feature. These are approximate numbers, and the science is evolving so fast, it's hard sometimes to verify those numbers. But the bottom line, cleft lip and palate is more commonly multifactorial, but can be associated in syndromes. When we think about heart defects, the baseline risk, as we listed here, about 0.8% or 9 in 1,000 live births. Interestingly enough, when the mother has a heart defect, now we have an increased risk in the fetus, 5 to 10%, pretty significant. So I always mention this to folks because if you have on your case list a case where there is a maternal heart defect, you might be asked about fetal cardiac conditions. If you have a case on your list where there's a fetal cardiac condition, you might be asked about maternal cardiac conditions because there are some relationships there. Again, some things are clearly genetic, we know the link, and some things are multifactorial and involve both genetics and environment. I'm going to talk just for a second about Turner syndrome. So Turner syndrome, that's 45XO. This used to be, and I think it's still sometimes advocated to be the most common genetic result from analysis of a first trimester pregnancy loss. I haven't looked at that recently, but it's definitely a common cause of first trimester pregnancy loss. But it's also compatible with life and patients with Turner syndrome. When I was a medical student, there was a thought that there was some mental impairment, but that's not true. They have normal mental function, but they do have some very significant issues. Short stature is the most characteristic finding for Turner syndrome. Renal anomalies occur in about 30 to 40%. They're at increased risk for aortic dilation and dissection. We do see Turner's patients, by the way, who conceive with IVF. They're usually infertile, but they conceive with IVF. And when we do, we always have to think about the risk for cardiovascular complications and whether or not they can have labor and delivery or should be delivered by cesarean section. Again, related to that risk of aortic dilation dissection. Hypertension is relatively common in Turner syndrome patients. They, of course, have a hypoestrogenic state due to primary hypogonadism and non-functional streak ovaries, and also infertility associated with that. They're going to be on hormone replacement as a child for normal pubertal development, and they'll be on hormone replacement as an adult. We will often manage that. And because of these hormonal issues, they are at increased risk for osteoporosis and fracture. So we want to optimize that as well. And again, I did mention that pregnancy can be achieved with assisted reproductive techniques with IVF. All right, I'm going to go on. So in this slide, I'm going to mention something that we sometimes do and a lot of board review faculty do. We will make something a little bit easier for you to remember than it actually is in real life. What I'm talking about here is this gets to the question, which is a common question. What would be the risk for a patient to have trisomy 21 in their fetus based on age alone? If they're age 35 versus 40 versus 45, and what would be the risk of having any major genetic anomaly? What we've done here, I like to call this lecture license. We have rounded the numbers off ever so slightly to make them easy to remember. They are very close to the real numbers, and they would absolutely suffice if you don't have the real numbers already memorized, okay? So don't spend a bunch of time trying to memorize a million nitty-gritty numbers when the trend, 1 in 350, 1 in 100, 1 in 30, 1 in 10, pretty easy to remember. You can see the pattern. On any major genetic anomaly, 1 in 200, 1 in 50, 1 in 20, 1 in 5. These numbers are very adequate. And this is a question that if it comes up, you'll look better having these approximate numbers. And you can always say, some people are very literal. So they'll say, well, it's approximately 1 in 350. Okay, great. That's even better. You're right on. So remember that the mid-trimester risk is a little bit higher for trisomy 21 because some of those pregnancies end in miscarriage or IUFD. So at the mid-trimester, it's about 1 in 270 for a 35-year-old, and at term, it's about 1 in 350. Also remember something that confuses many of us: the risk is higher when it's 1 out of a lower number. So 1 out of 10 is a lot higher risk than 1 out of 100. And sometimes we get that confused. Okay, so just keep that in mind. Remember that with we're talking about trisomy 21 because it is one of the most common genetic sort of example cases, because there's a lot of experience and knowledge about it. Remember that there are different causes. The vast majority are spontaneous due to non-disjunction, failure of all the chromatids to separate along the metaphase plate during mitosis so that one pole gets an extra chromosome. Okay, just remember sporadic, spontaneous. It's 95% in that are going to be that situation. The risk for familial Down syndrome, if you're given a situation, a case with familial transmission, now we're talking about a Robertsonian translocation. This has to do with part of the chromosome detaching from where it should be and attaching to a different chromosome. So the person who has that detachment, that rearrangement, or that translocation, as we call it, they have a normal amount of material, but when they pass on an unbalanced half, and it leads to trisomy 21. It is really important that you can talk about your genetic screening and diagnosis approach. There are a lot of screening tests that are in use today, and we've listed them for you here. No single screening test is superior to any other test in every way. That's direct from ACOG. So you need to be able to be clear about a couple things in the exam. First, you have to be crystal clear about the difference between a screening test and a diagnostic test. We really should never take action like a termination of pregnancy based on the results of a screening test. I think this has become a little harder for people to contemplate with cell-free DNA. But remember, cell-free DNA is a screening test. And if you're going to take action like termination of pregnancy, you must have a diagnostic test to confirm that result. Okay, so it's very, very important in the oral exam that you are clear on this if you get into discussion of genetic screening and diagnosis. You also should be familiar with which tests you offer or utilize in your practice, specific in your practice. And for those particular tests, what is the gestational age range at which they are appropriate? What is the detection rate, at least for Down syndrome as an example? It's nice to know the screen positive and false positive rates, the pros and cons for each test, the components that are in it. What does the test actually measure? And really critical, they'll give you the scenario, okay, if the test came back with increased risk, how would you handle that? And I think we're all very comfortable with that in clinical practice, but it may not be something that we have summarized verbally in 2 or 3 sentences, which we need to be able to do. Here's a classic example of a screening test, the quad screen. We present this only because it's been around for a long time. It's very well known to your examiners. It is still in active use in a lot of practices and communities around the country. It is a second trimester test. It has a lower detection rate. The detection rate for trisomy 21 is approximately 75%. It also has a relatively moderately high false positive rate, about 5%. It has 4 components: MSAFP, HCG, estriol, and inhibin. And when I think about the results of those, I just always remember high is high. So HCG and inhibin are elevated, and the other 2 go down. High is high. I hope that serves you well if you have never heard that before. All right, so this is the quad screen. I think the quad screen as a historical test is still relevant, even if you're not doing it. It would behoove you to just know a little bit about it in case they told you in a structured case that a patient had a quad screen, then you'd be familiar with it. Okay. A couple of other tests that are out there that are routinely used, but maybe not in your practice. So just for you to think about if you do use them to know the details. First trimester screening, which usually includes a nuchal translucency, excuse me. Sorry. feel that sneeze coming on. First trimester screen, nuchal translucency with blood testing. This is similar in accuracy to a quad screen, but the information is obtained earlier in pregnancy, allowing more time for action and or planning and action. The integrated screening. So here we have the nuchal translucency, the first screen and the second trimester screen, and the results are released once all of the testing is complete. Sequential screening is kind of like integrated screening, except that the first trimester results, if abnormal, are released, and then the second trimester results are done if the first trimester results were reassuring. And the final result, of course, comes out after the second trimester. So that's the sequential screen. Cell-free DNA. I know you're all familiar with cell-free DNA. So a couple of things. It's non-invasive in that it tests for fetal DNA from the maternal plasma. The fetal fraction is really important, and it's approximately 10%, 10 to 14 weeks. One of the problems with reporting when you get a no-call report from a cell-free DNA is when there's a low fetal fraction. It's one of the reasons that can occur. It is a low fetal fraction or no-call result is associated with increased risk of aneuploidy. There's a higher chance for a low fetal fraction if you test earlier, less than 9 to 10 weeks, and also with other certain factors like obesity, Black race, use of low molecular weight heparin before 20 weeks is associated with this, IVF, twin pregnancy, and per fetus in a twin pregnancy, the fetal fraction is actually lower than if you had a singleton. The cell-free DNA has some advantages. It's got a very high detection rate for the common trisomies that we look at. It's got a very low false positive rate, although the false positive rate is higher in very young patients because the number of absolute positives, I'm sorry, not the false positive rate, the positive predictive value is lower in young patients because the number of actual positives is so low. So again, there's some statistical stuff with the use of cell-free DNA in younger women that can sometimes be kind of complicated. The other thing about this is the only screening test that we do that can identify gender and sex chromosome aneuploidies. So just be aware of that. Okay, we talk about diagnostic testing, amniocentesis versus CVS. There are different analytic methods for evaluating the sample. This can include FISH, traditional chromosomes, or chromosomal microarray analysis. And I want to mention on chromosomal microarray testing, this should always be offered to patients, recommended to patients who are getting their diagnostic testing because they had an ultrasound showing a structural abnormality. Okay, so when we think about doing a amnio or CVS because there's an ultrasound showing a structural abnormality, it's usually going to be an amnio we'll be doing there. We're going to recommend chromosomal microarray because it's going to give us more information than the karyotype alone. When we think about amnio versus CVS, this is another one of those compare and contrast slides. So this is just to give you a little bit of information, differences between these two tests. The one I always point out that can you evaluate all the same information with these two tests? The answer is no. You can't do a neural tube defect screen, AFP screen on a CVS. So CVS, you're going to have to do a second trimester evaluation for AFP. Carrier screening. So very, very important as part of preconception counseling, also comes up in prenatal care. I'm just going to briefly mention, there are a couple of ACOG publications on this. There are a lot of different ways this is done, but there are some minimum things you must be clear on. ACOG recommends carrier screening for 2 conditions for all patients. That's cystic fibrosis and SMA. They also recommend all patients be evaluated for anemia, and where anemia is present, all patients should have a subsequent evaluation for inherited causes, including sickle cell, trait, and disease, as well as thalassemias. So 3 things all patients should get: cystic fibrosis, SMA, and a screen for anemia. Fragile X, not recommended for all patients, but I'll talk about that in just a second. In high-risk populations, the Ashkenazi Jewish population, there are additional tests, the four main tests that are clearly recommended, Tay-Sachs, cystic fibrosis, Canavans, and familial dysautonomia. And they're listed here. The numbers in parentheses are the carrier rates for this high-risk population. And so all four of those tests should be offered to all people of Ashkenazi Jewish descent. And then the other list here are the may be offered tests. Okay. Now, I will also mention that you may be using an expanded panel for carrier screening, and that is also acceptable. So if you're using an expanded panel, you may be getting more tests than are absolutely recommended. And there are some issues related to that. What about when you get back a result where there is no clinical significance clearly established for that test? And how do you handle that? So there's a couple of unique questions that could come up with expanded panels. So I am going to continue. I'm going to talk for just a second about Fragile X. So, Fragile X, this is an X-linked recessive disorder involving the FMR1 gene that relates to the production of this protein. When production is decreased, then you have the increased incidence of phenotypic abnormalities. So the issue that's interesting about this is that it's related to the number of repeats in the gene sequence. So these trinucleotide CGG repeats, if they're less than 45, this is somebody who doesn't have it. If it's 55 to 200, 45 to 54, that's in the intermediate range. If it's 55 to 200, it's considered a pre-mutation. And if it's greater than 200 repeats, it's a full mutation. And it is X-linked, which means that when a mother passes a full mutation to her son, he will definitely be affected, but not always true for her daughter. And the effects of Fragile X include things like autism, the developmental delay, the Fragile X ataxia syndrome, a premature ovarian failure for the females that are affected. So I want to mention, when we think about Fragile X, it's the most common inherited cause of intellectual disability. And it's the most common single gene cause of autism spectrum disorder. I have given you a very, very brief overview. I did not even touch on the fact that the number of repeats can expand as in successive generations, depending on whether it's inherited from mom or dad and into male or female offspring. So I'm not even going to go into that today. I simply would say this: Fragile X is a topic that is worth, especially if you have it in your case list, worth slightly more attention. I do want to point out something on this slide. The slide states that CVS may not be as accurate as amnio. That is because sometimes with CVS, particularly when because it's done earlier, it may not be able to assess the methylation status of this gene, and that's important. Methylation status is one of the predictors for phenotypic effect. So again, CVS may not be as accurate as amnio in this evaluation. Very interesting condition, and I could spend a couple of hours on it, but I'm going to continue because I have to. We have a lot of things I want to cover in the next couple of minutes. Neural tube defects, very, very high yield. Multifactorial etiology, second most common anomaly after cardiac. The occurrence or recurrence risk relates to the number of affected family members. It increases as there are more affected family members. When a patient has a history of a neural tube defect, it's recommended that we start folate 1 month before conception and continue for the first 12 weeks, and they're going to get a higher dose, 4 milligrams of folate per day. When we give additional folate to these patients, we need to do it as a prescribed supplement of folate alone. Doubling up on multivitamins, on prenatal vitamins, is not a good idea because they'll get potentially harmful amounts of some of the other vitamins in the prenatal. All right. 30% of neural tube defects are not prevented by folate supplementation. This is what they call folate-resistant neural tube defects. They're due to other causes. This can be valproic acid, high glucose levels, elevated maternal temperature in the first trimester. We do universal ultrasound at 18 to 22 weeks. And one of the things that we're looking for is neural tube defect. If there is an abnormal MSAFP, definitely going to do an ultrasound and look for other anomalies as well, because a body wall defect could also produce an abnormal MSAFP. Mode of delivery for a fetus with a neural tube defect is individualized, depending upon what defect is identified as to whether or not they can have a vaginal birth or a cesarean. Last genetic issue, just another one of these compare and contrast, gastroschisis versus omphalocele. This is just a slide that gives you some of the sort of similarities and differences. One point I want to make about this, the normal embryo in the 9 to 10 week time frame, 9 to 11 week time frame, can have the appearance of an omphalocele. This is the herniation of the hind gut. It can be seen on ultrasound. Now, you'll never see what looks like a gastroschisis as a normal finding, but as an omphalocele, what appears to be an omphalocele, in that particular period of development, you could see on ultrasound. Omphalocele usually has a membrane. Gastroschisis does not. Gastroschisis is essentially a development of the body wall defect, and it is not usually associated with other genetic problems, where omphalocele is often associated with other genetic syndromes and abnormalities. All right, I'm going to just very briefly finish up with a couple of patient safety and communication issues. Realize that medical errors are a common cause of death during medical care. It's unfortunate, and it's something we want to prevent. Miscommunication is the leading cause of sentinel events. 2/3 of all sentinel events, these are events identified for additional investigation because they are significant, are related to miscommunication. So any way we can minimize miscommunication is going to be important, including when we hand off patients and using protocols and checklists to increase our standardization and our communication. Now, protocols and checklists are not a substitute for sound medical care. They help to make good doctors better, okay? I want to emphasize that most medical errors are related to the use of medications. Miscommunication regarding the use of medications. In OBGYN, there are several medications we commonly use that are implicated in some of these problems, including things like magnesium, oxytocin, and insulin. So we have to be very careful. We always want to follow the 5 rights of medication use: right drug, right dose, right patient, right route, and right time. Not as important, but another issue that does come up, errors that occur in the surgical environment. And they occur most commonly because of distractions, okay? When we have multiple surgeons, multiple procedures, unusual time pressure, which is another way of saying when we're rushing. When we have distractions like teaching situations, inadequate staffing, and exposure to outside influences like beepers, radios, or telephone. So again, surgical errors, we have to be very careful to try to prevent these by establishing the right environment. And one of the things that's recommended is the timeout to avoid wrong site surgery. Correct patient, correct side, correct level when it applies. Signed consent, checking patient positioning, necessary imaging to be available in the OR to confirm when necessary what we're doing. Antibiotics, whether they're required or not, are usually added to this to make sure that prophylactic antibiotics are always given when they should be. And this is my last slide for the office lecture. Patient safety and communication. I just want to remind you that handoffs are more common today than they were 20 years ago. 20 years ago, due to no restrictions on work hours for residents or physicians, the sort of mindset was your patient is your patient 24 hours a day, 7 days a week. Even when somebody was covering for you, you were usually still kind of checking in on your patients to make sure everything was good. Today, handoffs are a part of what we do, and they probably result in better, definitely better lifestyle and hopefully better patient care because we don't have traumatized, fatigued physicians taking care of patients as much as we used to. So handoffs, physician to physician is ideal. There are lots of different situations in which they come up, from the office to the hospitalist, from the generalist to the specialist, from the attending to the resident, from the physician to the nurse. We should have interactive communications during a handoff. We don't want to be interrupted. We should have a process for verifying information when it is given, and an opportunity to review any relevant historical data. A mnemonic that is commonly used, I pass the baton. It's part of a program called the Team Steps program, which you probably are familiar with, which was developed by a component of the US government for reduction of medical errors. I'm not going to go into more detail. Again, I could, but we are out of time. So this is the end of the office section. And I know it has been a whirlwind of a presentation, and I have tried really, really hard to direct you to some key pieces of information, sometimes hit on them multiple times. I hope that you find this helpful. And if you have any feedback or questions, again, always feel free to reach out to us here at ExamPro. I'm going to answer the questions that I have, and then we will move on. I'm just checking to see where we are at on time. We will be fine. Okay, so for the question and answer, I'm just going to click on the question and answers at the bottom. Is smoking a contraindication to HRT? The answer is smoking is not necessarily a contraindication to HRT. Smoking is a risk factor for VTE. HRT is a risk factor for VTE. It would be a shared decision-making process, potentially a lowest dose, shortest duration of time, of course, really applies there, but again, not an absolute contraindication. And let me just continue here because I have more. So if we're in a fellowship, when asked, what do you do in practice for something like, so if you're in a fellowship like Eurogyne, what would you do if you're asked, how do you handle in your practice something like pregnancy, genetic screening, and diagnostic testing? Can we answer by saying, I do no longer take care of prenatal patients, however, previously I did cell-free DNA? So you can always say something like that. I will tell you, most of the time, it's going to be obvious that you're a fellow from your case list, okay? So when you say something like, I no longer take care of prenatal patients, I know the intent is to be transparent, to say to the examiner, this is not my area of expertise, but it sometimes actually goes the other way. So it will make the examiner sort of think this is a disclaimer. It's sort of saying, I don't really know very much about this because it's not, I'm not interested in it. And I know that's not what you're saying, okay? So the question becomes, if you say, well, my preferred test would be cell-free DNA, great answer. You said my preferred test. You didn't say you did it on anybody yesterday, but you've done it before in the past. So if they then say, well, when's the last time you ordered a cell-free DNA? Then I would say, well, a couple of years ago, because it's not part of my everyday clinical practice. But the bottom line is that I think it's not so helpful to say that I don't do this anymore when it's a general topic, okay? If they get into more subspecialty stuff that's out of your league, then the answer would be I would refer. And I would refer because I want the subspecialist to help me with X, Y, and Z. So in general, practice, get comfortable, say, well, my preferred approach to this would be, that's just saying you as a physician, your preferred approach is, it's not being deceptive, and it looks better than saying, well, I no longer take care of this group of patients, because that always comes across somewhat like an excuse, which I know it's not, but we want to try to minimize that where we can. So that is it for questions.